Welcome to you. Thank you so much for joining us for the Elisabeth Kübler-Ross Foundation community conversation with my friend and colleague, Gabby Jimenez, and we are going to get started here because there are a lot of you joining us, and there's a lot for Gabby to talk to you about. So thank you so much. It's so wonderful to see you. We've not been able to offer these as often as we had before, so I'm always grateful when people are able to join us. And I want to just start by asking people if you were willing to put up in the chat where it is your chat zooming in from. And I'd be curious to if you've ever been to an event before with Elisabeth Kübler-Ross Foundation or an event with Gabby. And for those of you that are new to us here at the Elisabeth Kübler Foundation, I want to welcome you and just give a little bit of background that we are a not-for-profit organization that currently is only being supported by donations through our community education program. And the foundation was inspired by the life of psychiatrist, humanitarian, and hospice pioneer, Dr. Elisabeth Kübler-Ross. And it's in the spirit of embracing all of life, which includes death, that we further Elisabeth's mission and her vision through collaborations, education, and advocacy. And for those that have been following Elisabeth's work for some time, Saturday is the 20th anniversary of her death, which seems impossible that it's been that long. I'm also going to ask people if they would mute themselves. Gabby, I'm going to not mute you, but we are going to ask people if they could just to be mindful of keeping themselves muted. And thank you for those that are posting up there. I want to just spend a little bit more time with the foundation. Ken Ross manages the foundation. He founded this shortly after his mom's death. And he was looking forward to being here, but then he was invited by the Guatemalan chapter, where they have trained over 90 palliative care doctors and nurses in the last 2 years. They've opened a respite center for people dealing with long acute illness and end-of-life issues. And they also, through the collaboration of the chapter president there, a wonderful woman named Wendy, her family, and some connections Ken has, they are also feeding people in 17 villages in some of the poorest regions of Guatemala. He's also going to Singapore, where the St. Luke's Hospital there has trained almost 100 physicians and nurses now, and are supporting people in places like East Timor and Nepal, where they have up until now, no palliative care. And then on, I think next week, he's going to Peru to visit Monica, who is a fantastic person who's married to one of my dear friends, George, from the Stephen Levine days. And Monica had a vision probably 20 years ago when she was working in Lima, Peru, and volunteering at the Ronald McDonald House, that people coming from villages in the poorest parts of Peru, the Sacred Valley, very close to where Machu Picchu is, were traveling in some cases by car for 19 hours, and in other cases for 2 or 3 days with their very critically ill children, to go to Lima to have them cared for in a hospital. And Monica has, in the finishing stage of creating one of the most beautiful structures, a little village in the Sacred Valley, for respite for these families, for children can come and see a palliative care doctor, where they can provide appropriate end-of-life care for children that are ill, and also education for the other children in the family that might need to come with, so they're not going to be left in their villages. So we're doing a lot of work in other parts of the world, and we're really grateful to all of you for supporting it by joining us. I want to now introduce Gabby, and I could spend hours introducing Gabby. I first met Gabby, I think, very shortly after I started working at Mission Hospice, which is a local not-for-profit hospice in San Mateo, California. It's now part of a much larger system called Health by the Bay. But Gabby is a hospice nurse. She's an end-of-life doula. She's a death and dying educator, and will benefit from that this afternoon. She's also an author, a blogger, and she's got a social media platform of almost 150,000 people, which just boggles my mind. She didn't do this work for most of her adult life, But after helping to take care of a friend who was dying, she changed her life by going back to school in her late 40s to become a nurse with a desire to work in end-of-life care. And she sees that this was her path all along, and she's so grateful to finally have found her passion. Gabby's going to talk about her high regard for the wishes of her patients by finding out what's most important to them and to those who love them, and how best to honor them. And there's a lot more that I can say. She teaches classes, and we'll put this information in our follow-up email to you. We'll give you a bunch of links. We'll put some of them up at the end of this class. And she has a beautiful website called the Hospice Heart. We'll also post that. And one of the things that I just am so grateful to Gabby for is that last year, my day job is with the Humane Prison Hospice Project, and Gabby joined us as one of our facilitators. And we go into prisons in California, and eventually we'll be going into prisons in other states, Washington, Nevada, Washington, and Oregon, and possibly Michigan. And we train people who are incarcerated, who are living in the prisons, how to be end of life, palliative, and memory care workers so that they can support their peers. And it is the closest to what hospice was intended to be that I have ever gotten. And Gabby is one of our facilitators, and she is just wonderful. So without much further ado, Gabby, I'm going to disappear here, but I'd like for you to just introduce yourself a little bit more. And Gabby's going to start her presentation. Thank you so much.
Thank you, Susan. Hello, everyone. It's so nice to see all of you here. I recognize so many names and faces, and I'm just amazed at where you're all coming from. This is amazing to me. I love Zoom. I love that it brings us together in a way that we might not have ever had that opportunity. So thank you, Susan, for that wonderful introduction. I teach and I present a hospice masterclass. The class itself is about 2 hours usually, sometimes a little longer. And I do have Zoom classes. I also present it in person at libraries for free. And I'm also now doing it in assisted living and elder care facilities for free, because what I'm finding is that there are so many people that have absolutely no idea what hospice is and what's available to them. I can't tell you how many times I've heard someone say, my mom went on hospice and she died. And I want to say really matter-of-factly, but of course, wrapped gently with compassion, but your mom did not die from hospice. She died from the illness and the decline and the disease process. But it's really hard for people to see that. And my thought was, if we can educate people, more people, a lot of people, about the benefits of hospice and what happens and what resources are available to you, maybe they would be less afraid, have less fear that hangs over it, right? Maybe we could honor some of their curiosity and comfort some of their uncertainty. And it doesn't take that much time to do it. And imagine the difference we can make in the end of life for many people, right? And I don't mind doing it for free. I also like the money, I'm not going to lie. But my whole purpose is to help improve the way people are cared for when they die. Not just by their family and loved ones, who are the ones that don't have the tools, but also for the employees, for employees of facilities. I have recently witnessed quite a bit of people who transition, for instance, from an assisted living an independent living to an assisted living. And the staff of the assisted living and the memory care are still working from the mindset of independent living. They don't have the education and the skill set, and it's not their fault. They don't have the knowledge of the transition from that decline. And there is such a difference in how you care for someone who is aging, but has, very limited symptoms and doing pretty well or very independent, compared to the people who begin their decline and need full service and assistance. You can't go from one to the other providing the same care. It has to change. And so that is one of the reasons why I do this. I want to make sure that people have the tools, not just so they can provide the care, but so they're a little less afraid. What I'd love to know is that I handed over the tools to make someone else feel more confident at the work that they're doing, especially family members. So first, I want to tell you what hospice is and a little bit about what it isn't. Hospice is not a diagnosis. You've probably heard me say this a million times if you've heard me talk. Hospice is not a diagnosis. It is a plan of care for the diagnosis. Hospice is not the cause of the death. The diagnosis and the disease process is. And we need to separate that. Hospice is an opportunity to honor the person that you love who is dying in a way that addresses everything that they might go through physically, emotionally, mentally, and spiritually. So what I want to do is this again is a very short version of my usual presentation. So I'm going to kind of rush through it. So just hang on, get a pen, and you can watch the recording when she sends it out later. But just hold on, you guys, we got this. So first of all, one of the things that happens when someone starts hospice is they have a team, right? It's a collaborative team that comes together. We are not a solo act. We are a team that does this work beautifully, I think, together. Now, keep in mind, I understand that there are people who have had bad experiences with hospice. I am blessed to work for a company where I can say we really do beautiful work. And I think most people in general who do this work do it beautifully. But sometimes there are things that go wrong. But in the messages that I have received from my hospice heart community, where they've shared that their hospice care was not up to the par that they wanted it to be, it was often because they did not have the education or the information to prepare for them what they were to expect. I think part of our role as a member of the hospice team is to prepare every family member for what could and might happen. Doesn't mean it's going to, but if you prepare them, I think there will be a little less fear. I think it's also important to let each family member know that hospice is not the boss of you. You are not required to stay with that hospice or that member of the team that has come to meet with you. You can change it. That's okay. If you don't speak up about how you're feeling, then you're setting yourself up for failure. You need to ask the questions. You need to put it out there that you need to know the why that we're doing this, the why that we're doing this. And so I'm going to give you some of those answers today. And remember, this is a short version, so I'm going to kind of rush through some of the things. So first you have a team. The team, I think, always consists of a doctor, right? You're attending. Now, you will probably not see the doctor. That's very rare that they come to you, but sometimes they do. Sometimes you might meet them over FaceTime, but they're always there. They're kind of like the Wizard of Oz, right? They're behind the curtain. We know where they are, and they're available to us at all times. Well, usually. The doctor is there to help us as nurses manage symptoms and medication and the changes in the decline of someone who is dying. The case manager is a nurse and is an RN, and they are your main point of contact. You will see this person once a week, sometimes more, depending on what you're going through. The two people that I think are not as well known, but you should know who they are your social worker and your chaplain. The social worker comes to you with incredible resources, so much knowledge and experience. And yes, can they address your sadness and ache and everything that you're feeling from your anticipatory grief to your grief journey? Yes, but that's not all they do. They can help you with the funeral arrangements. They can help you with letters that you might need to send to your company or school if you need to come out to visit your family. They can help you with so many things. And it's really important that you at least meet with them once so that you can find out what they might offer you. Hospice does not offer caregivers. That's a misconception. However, your social worker can help with finding you the resources to provide the care that your person needs. There are a lot more things that the social worker does, which is why I really want to encourage you to meet with them. The chaplain, I think people think the chaplain's coming to you to talk all about religion. And while they have that experience for sure, it's not just about that. It is about your spiritual experience at the end of life. Oftentimes, it's simply to be present and listen to your concerns and curiosities. People with a really strong faith tend to have less fear at the end of the life because they know where they're going, they know what to expect, they know who's going to be there when they arrive. People without a strong faith have more curiosity and oftentimes fear, and find themselves at those last few weeks or days wondering, what is going to happen to me? Will I go to heaven? What is heaven? What is it going to feel like? What does this all mean? There's so many questions. And the chaplain is probably one of the best listeners on the team, but they don't come to you with the idea that they're going to fix you with religion. They're going to come to you and honor your spiritual curiosities in a way that is incredibly beautiful. I encourage you to meet with the chaplain. When my brother died 2 years ago, the chaplain in the hospital, there was 3. The first one came in and wanted to talk about religion, and I said, no, thank you. And the second one came in and she was very busy telling me about her personal stuff, which I thought was odd. So I said, no, thank you. And the third one was this gentleman. He came in and he just said, is it all right if I sit with you? And I kind of looked over and I said, okay. And I honestly was prepared not to talk to him. There was no need. I didn't need him. But his silence was golden. And I found myself really comfortable with that. And every day he sat with me. And in most cases, we didn't talk at all, but his presence was so incredibly lovely. The night that my brother died, it was him that called me and said, you need to come to the hospital. I think it's close. And it was him who gave me my first hug when my brother died. And I realized that it was his presence that brought me so much peace. I encourage you to definitely welcome at least the first visit from the chaplain. We also have home health aides, which offer bathing in the bed or in the shower. They're only there for about an hour. They're not going to do housekeeping or dishes or your windows, so don't expect that. But they will be there to bathe and care for your person in a way that they deserve, a beautiful, beautiful, dignified way. The other thing that is really important about them is that they are another set of eyes for all of us in the hospice team. They see things we might not. They can see when there's skin breakdown and changes, or maybe there's some disconnect or something happening in the family that we might not have seen. So it's another pair of eyes besides the nurses, the chaplain, the spiritual care. We also have our volunteers, which personally are my favorite. Volunteers and end-of-life doulas are very similar. They do the same work and they come to it with the same intention, which is completely heart-centered and compassionate and kind. The end-of-life doula is not a part of the hospice team, and I don't believe that they will be anytime soon, but I'm not giving up hope. But they do add to the package of what offers care and compassion to your person. But the volunteers are so incredibly well trained that they also act as a second pair of eyes. But because they come to this work without any need for financial, of course, because they're volunteers, but they also don't need accolades or a pat on the back or an announcement of the wonderful work they did. They actually come to this work simply because they are truly called to it, and they want to be present for someone who is declining and dying in a really beautiful way. The volunteers are often the one person that your person will share everything with when they can't tell others. Because often that person in the bed, the person who is dying, they are often afraid to tell their loved ones how they're feeling. Maybe they don't want to burden them with their pain or their fears. Maybe they have some past thoughts and regrets of their life before this moment, but they can't tell anyone about it. The volunteer is like the secret keeper, the safe place to share all of your vulnerabilities and just the things that go through your head. And so the volunteers are an incredibly necessary part of the team. They also can act as respite if you need to take a break or leave for a little bit or go to a doctor's appointment. This team is collaborative. We all have the same intention, which is to make sure that the person who is in that bed, who is soon to take their last breath, has a landing that is soft. We are not a solo act. We do this together. Now, you have a team. That's a very valuable part of the hospice, what comes with the hospice. But supplies is as well. I see families often spending a lot of money on supplies that they don't have to. Because this is part of your hospice benefit, something that is paid for under the Medicare benefit, everything that we supply is covered under that. We can actually save you some money. Typical supplies are a hospice bed, a hospital bed, a bedside table, a commode, a wheelchair, a walker, oxygen, maybe a nebulizer for breathing treatments, shower stools. I mean, just most of the things that you might need to care for someone who is declining. It also covers medical supplies, like incontinence supplies. They're not the best names. They're not pretty, but one package of adult briefs can be $15 to $25. That's a lot of money, especially if you go through 2 a week. We supply those, and gloves and disposable pads and wipes and body shampoos and lotions and things that might make things easy. For instance, if you have itchy skin, which happens at the end of life, there's special creams that we can provide. We also do wound care. We provide the tools necessary for that. 1 box of foam dressings that is $65 for 10. Imagine if you had to pay for those. We do the wound care. We provide the wound care supplies. All of that can add up, but people don't realize what we do, what we offer, and what a difference it could make if we do that for you. Medications. Not all medications are covered, but most of the medications that are relative to the diagnosis and the symptoms that come from that diagnosis are covered. I just had a patient who was using a special cortisone cream, and they were paying $135 out of pocket. That's an awful lot of money. I went to the doctor. I asked if we could have it covered, and he said yes. I just saved them $270 a month. That's a lot of money. So it's important to know that hospice covers a lot of things that you think you have to pay out of pocket, and you don't. The care, in my opinion, is heart-centered and beautiful. And again, it helps to allow you the comfort in knowing that your person is being cared for well, but also that we hand over the tools to you so you can do this work as well. When I first started working in hospice, and just to give you a little bit of a backstory, at the age of 47, I went to nursing school to be a hospice nurse specifically. I wanted to care for people who were dying because I wanted them to have the care I felt that they deserved and I didn't feel was happening. I used to manage commercial real estate. This was definitely not in my wheelhouse. I think now when I look back on my childhood and my life growing up, I know now that I was meant to do this. I just wasn't ready yet. So when I became ready, I did it. And it wasn't easy. Going to school at 50 is not an easy thing to do, but it's been the best thing I've ever done because I am truly doing something I'm passionate about. And I have learned so much. Now, this team comes together and they provide beautiful care. They're for your person who's in the bed, but they're also there for anyone who is sitting at the bedside. Now, again, what I was going to tell you is that when I first started doing this work, I had this idea that I would come in and do all my nursing stuff, right? And oh, everybody would be so happy and everything would be great. And then I'd leave. It never occurred to me early on to hand over my tools to the people who will actually be doing the care when we walk out the door. What I found was that I was actually, in many ways, leaving them empty-handed. They would call the triage line and say, we don't know what to do about this. And so I realized I needed to change the way I do what I do. And so every time I see a patient, whether I only get one chance with them or have multiple visits, I always leave them with something that makes them feel more confident. I offer an explanation and the why to the reasoning behind our symptom management. I sit with them and ask them, what are you struggling with most? What can I do to make you feel more supported? What do you need from us? I never ask a patient, how are you? I know how they are. Instead, I'll ask them, what can I do for you? And I'll ask the family those same questions. I ask them both because what I want them to know is that I've got them. I am here for you and nothing else matters right now but you and what you need. And that is so important because that person lying in the bed needs to know that they are seen and heard and that they have a voice. When someone is given a terminal diagnosis or they're just simply declining from age, their autonomy, their voice, and their choices are taken from them. We tell them what to do. We tell them when to go to bed, when to get out of bed, when to go to the shower, when to eat, what to say, what to do, what to wear. They don't have a voice. As a hospice nurse and an end-of-life doula, my most important goal, besides making sure they know they're not doing this alone, is to let them know you have a voice and I hear you. And you have a voice and you deserve to be heard. And your person, your family, your partner, whomever it is that you might be caring for, professionally or personally, deserves to have a voice. That's our job. Now, I get a lot of questions about the things that people are most afraid of at the end of life. Now, remember, this is the short version to my class, so I'm kind of whizzing through it. So just bear with me a little bit. But I'm going to talk about a few of the things that most people are uncertain about, or maybe there's a misconception. Certainly, all of these are laced with fear. So I'm going to share a couple of them. One of them is the death rattle. I don't like the name of it. I think it just sounds pretty awful, but it is what it is. And I've learned to make peace with that. And I'm going to give you my interpretation of what the death rattle is, and hoping that this gives you a little more comfort and relieves you of a little more fear. As we age in general, our throats begin to close. We struggle with swallowing. That is part of our body's aging and shutting down. But when we are dying, it does it even more. And we lose the ability to bring things up and bring things down. So often, anything we've taken in that is liquid, especially, right? It could be water, it could be medications. It sort of sticks right here. It can't be brought up and it can't be brought down. So it hovers and it makes this really, well, awful, rattling, gurgling sound. And it freaks everybody out. And I've had people say, my dad had that and I still hear it in the back of my head. And people equate it to suffering. I need you to know that it actually bothers us more than them. It's a noise. It's uncomfortable for us to hear, but it's not bothering them in the way it bothers us. Now, back in the day, like 2 years ago, we used to give things like atropine, which is an anticholinergic. But think of what that means, right? It dries out moisture. Well, if the secretions aren't pooling in the mouth, then that medication is drying out the mouth more than it already was. When someone is in the process of their body shutting down, the mouth dries, the eyes dry, the nose dry, and now we're adding more drops to make it dry. They don't reach this area. Neither does a suction machine. And I want you to also know that atropine has a side effect of hallucinations. I've been with 2,000 people who have died, and I've only seen it happen twice. So it's not something that's common, but just knowing that it might cause that is enough for me to say we're not doing that anymore. Now, if they're pooling in the mouth, which often happens, then that's when you can either turn their head down and let it spill out, or you can use a mouth sponge. But here's what we've learned. If you take your person and gently turn them to one side, and maybe to the other, depending on if that works or not, turn them to one side, prop them up with pillows, it will often move the fluid just enough to turn the volume down on the noise. Because remember, we're really doing this for you because that noise is so hard to hear. And if that's not as effective as you would like it, you can slowly roll them back to the other side. And again, it will loosen it up, often stopping that noise altogether or just turning the volume down just enough to make you feel a little more peace. And sometimes you can tilt the head down when they're on their side and just let them spill out. It's just spit. It's not going to hurt anyone. And it's leaving them, which is what we want. But I want you to remember, it bothers us more than them. It is a part of the dying process. It doesn't just happen at the very end of life. It can actually happen weeks before someone takes their last breath, but it is a symptom that happens often. And that also includes difficulty swallowing. You know, as people age, if they're if they're just having trouble swallowing, we will often put them on pureed or softer foods, right? Because that makes it easier, or thickener in their liquids. Well, if they're having trouble swallowing that tells you, that's an indication that they are having a hard time bringing things up and bringing things down. Two things I look for when I want to make sure that I know that they're having trouble swallowing is, the first one is when they cough drinking water. I'm not sure why it's water more than juice. Maybe it's the texture of the water. Maybe it's, I honestly don't know. But if they drink water and they cough, that to me is a sign. If they cough when using a straw, that is a sign. Straws are designed to fill up completely and shoot all of that liquid into our throat. For a person who's struggling with swallowing, that can be very scary, also incredibly uncomfortable. So what I tell people is stop with the straw and maybe switch to other liquids first. I'm not a big fan of thickener just because I wouldn't want to drink something with thickener in it, but it does work. You can try it, but try a juice first. But what I also do is I take our little 1 ml, this is a pen, of course, you know that. It's not a 1 ml syringe, but let's pretend for now. You take your 1 ml syringe, right? And you only fill it about halfway. There's no needles, just to let you know. These are our liquid medication syringes. And you just fill it halfway and you put those drops of water in their mouth. It's heaven because the mouth is so dry. And at the end of life, they're not wanting more liquids because they're thirsty. They're wanting it because their mouth is dry. Our need for food and water at the end of life ends. We don't need it. We lose joy for it. So when someone is drinking, it's usually because their mouth is dry. But people think that we as hospice workers are starving or dehydrating their loved one because we've removed food and water. The body actually doesn't want food and water at the end of life and will let go with a little more peace and ease without it. If someone is saying, I don't want that, respect that. You are not hurting them. They are not going to die from starvation or dehydration. The body will be grateful because it prefers not to have it. So they might cough, right? That's the first sign. But the other things they do is they might shake their head no. They might purse their lips really tight. They might pocket food in their cheeks, or they might spit it out. That is them telling you, I can't swallow anymore. This is uncomfortable and I'm afraid. So by you honoring that is actually making them more comfortable. And it's important that people understand that and not take it within them that they think that they're hurting their person. You're actually making them far more comfortable. So just remember that the body prefers not to have food and water at the end of life. And when we suggest stopping it, it's because we don't want your person to suffer. And it does become suffering because they will oftentimes choke. And that is a hard thing to react to and fix. One of my favorite questions and something that I've spent my whole career reassuring people is about the hearing at the end of life. Can they hear you? Absolutely, they can hear you. I think that the people who are dying have a sense of awareness that goes beyond anything we even have, right? They feel you, they know you're there, even when they're completely non-responsive. They pick up on what you bring into that room. It's really important that we're very aware of what we bring into the room as far as sound goes, because they hear it. Now, I have told people for my last 10 or 12 years that I've been doing this work that yes, it's important that you you know that they hear you, and whatever you say, they hear that. But I'm going to tell you a quick story, and some of you might have already heard this, but when my brother died, we had had a large gap of time, a little over 5 years, where we hadn't talked. And I'll be honest, the argument was his doing and the fight was his fault, but I allowed the time to take on, right? And I didn't try to make it better. I realized I had to give up. I had to make peace with our disconnect. And so I'm sitting at his bedside when he's dying. And every day I said to him, I'm so sorry, Ben. I'm sorry I wasted time. I'm sorry I didn't try harder. I offered forgiveness. I accepted his unsaid forgiveness. And every day for 18 days, I said, I'm sorry. Well, the day before he died, he woke up. They took him off the ventilator, off the oxygen. He even had a bite of applesauce. And I said, Ben, did you hear me? I talk to you every day. And he said, I'm sorry too. Now he took my words with him and I took his with me. Now I have the luxury of his words and many people don't, but it's important that you know that what you say is heard on multiple levels. The whispering, maybe the arguing at the bedside, the talking negatively about things or other people, maybe being on your phone, tapping away, maybe disrespecting somebody else who's there or someone in the family. They hear the music that you play, they hear the TV on, they hear the conversations in the background. I wonder if we are more aware that everyone around us hears us, would we be more careful with what we say? I think we would. And this is when the conversation is so important to know, right? Like what if you were in a deathbed, what would you want to hear? I have a 12-hour musical playlist because music is like a diary of my life. I want to hear my music. I don't want to hear what you want to hear. I want to hear what I want to hear. So if the hearing is elevated, they pick up on all of that. So it's important to know that what you say is heard. They will take that with them. You might not be given the luxury of words back, but know in your heart that they hear you. And oftentimes it's the I'm sorry or the forgiveness or simply the I love you and thank you for letting me be in your life and the goodbye. All of that is important to say. But it's not just the hearing that is elevated. It is the sense of smell as well. I've been in facilities that have like 4 different oil diffusers blowing throughout the space. I have a really strong sense of smell and most smells give me a headache. I want to ask the facilities often, did you check with the people that are in those beds if they actually wanted that or if they like that? No, because everyone is always so busy projecting onto other people what they think you need. Smells can be incredibly obnoxious and can give people a headache and can burn their eyes. That goes with flowers. I often use the stargazer lilies as a good example, right? The stargazer lilies are so strong. Now I've learned to pick out the little centerpiece, but they walk in, okay, they don't walk in, they come in a vase in my home and immediately I have a headache. So what I'm guessing is that someone at a bedside who has a strong sense of smell and might be sensitive to that will have a headache too, but they can't tell you. We have to be mindful of the scents that we bring into their space. It could be flowers, it could be the oils, the sage, all the things that we think people want at the bedside. But if they don't tell you, you don't know. So maybe you didn't get to have a conversation with them. Don't assume anything. It would be better, in my opinion, not to have any sense than to bring something in that might cause them some distress. But it also includes your laundry soap, your shampoo, your body lotions, your perfume. And if you haven't showered in a few days, that can really elevate in the sense department. So it's important to be mindful of what you bring into that room. They have an awareness. They know you're there. They sense your emotional reaction to everything's going on. They feel you. They hear you. They smell. If we just honor those things, imagine the difference we can make for someone who is lying in that bed. Another thing that's really important to know is that the body knows what to do. We get all up in its business, right? We have to do all our stuff to say how we're going to handle this person's death and what we're going to do to change the dynamics of it all. But at the end of the day, the body actually knows what to do. And we have to trust that. And sometimes there will be sounds, and sometimes there will be movements that are uncomfortable. Sometimes they die peacefully in their sleep. None of that can be predicted. As a hospice nurse, my role is to reduce symptoms like pain and suffering. And I don't just look at it as physical, I also look at it as emotional. And I do my best. Sometimes I'll start with a small amount of medication. I'm not a big pusher of medication. I want to find other ways to reduce struggle. But often we'll need more medication. That's just part of this process. And that's when medications become such a fearful thing for people, because someone will say to me, my mother was on hospice, they gave her morphine and she died. She did not die from the morphine. She died from her disease process. We use morphine in hospice. We use Ativan, which is also called lorazepam. We use medications like haloperidol, which is also called Haldol. Those are the typical medications. We use many more. The purpose is that, and our reason for handing you a bag of medications and asking that you have it in your home when you start hospice, is so that we know that you have the tools that we might need when symptoms arise. Some people never use them. Some people go through them right away. And they're scary. If I didn't know what I know, I would be afraid as well. It's important to know that these medications are designed to tap into the different areas of the dying process in a way that will bring comfort. Sometimes we will pair medications together, like morphine and lorazepam, also called Ativan. Our purpose for that is, imagine you have pain. Pain can increase agitation. You have agitation, that can increase pain. You give them both at the same time, and they can simultaneously drop down both of those, bringing your person with a little more comfort. Now, these medications that we use, we only give a little bit initially, and we might increase that, but they are not enough to end a life. Could they die after taking the medications? Yes. And this is why. Because the medications that we gave or you gave tapped into what that body needed in order to feel some relief, which allowed it to let go and do what it was already doing, but with a little more grace. That's the body's way of saying thank you. So you didn't end your person's life by giving them morphine. You gave them the comfort and, in many ways, the permission to let go. We're not in the business of over-medicating. I know people have had experiences and stories. I'm sorry that was the experience. I would never be that nurse, and I would never want you to ever feel that way. So I'm always trying to educate about medication because I don't want people to feel that way. But there are a lot of people that do. Medications are scary, but they are relevant in managing symptoms. But it's important to know that there are other things that can cause symptoms that look like pain and agitation. For instance, a wet diaper. If someone is lying in urine or stool, it is incredibly uncomfortable. Some people, because the skin becomes so sensitive at the end of life, it can feel like it's burning. Or maybe they have a strong sense of smell and they can smell it. You change that brief, that diaper, you can bring them comfort. Oftentimes their clothing might bunch up in the back, or the sheets will bunch up underneath them, or the disposable pads that are underneath them will bunch up, causing a lot of pressure in the back. If you just cut the back of the shirt open and just make it so it lies across them, and they can put their arms in it, but it's no longer bunched up in the back, what a difference that can make. And if they're lying in a hospital bed, oftentimes their back and shoulders are sunk down, putting a lot of pressure on their upper back, their shoulders, and their neck. What I like to do is get fluffy pillows and put them under the arms from the armpit to the elbow or even to the hand and elevate them. It's like a hug, right? Because it gets them cozy, but it also takes the pressure off the shoulders, the neck, and the back. If they're in a hospital bed, you can elevate the foot of the bed, and that can take pressure off the hips and the lower back. There are lots of different things that we can do that can bring comfort that don't take medication. And as a hospice nurse, that is my first go-to. I assess the situation. I see what's going on so I know what I can address. And then once I've done that, if that is not effective, then I will encourage medication. I'm not afraid of the medications, but it took me some time to get there. And I respect the families being worried and afraid. And it's important that we educate and acknowledge that. One of the questions that I have witnessed, well, situations that I've witnessed, which causes such fear, is when someone is lying in a hospital bed or in any bed really, and they've been lying that way for a long time. And let's say we maybe roll them over to one side to change them or lower the head of the bed. That can often initiate the dying process, and they will die in that movement. I look at it this way. When someone is sitting in one position for a long time, it can kind of put the dying process on hold for a minute, like they're on pause. And when they're moved, after not being moved for quite some time, especially lowering the head of the bed, it like starts it back up again and allows that person to die in a way that they were already doing, but they were on pause. It's not anything that you did wrong or the caregiver did wrong or the nurse did wrong. It's not that you let your person down. It's that you kind of push the unpause button and let them finish the process they were already trying to start. But it doesn't cause them harm or discomfort. It just allows them to finish, which they deserve and which we want for them. Being on pause is probably just as uncomfortable. I also get people that ask me, why are they taking so long? Right? So they've come on to hospice, they've gone through their process, some are shorter than others, and we'll tell them, you know, they're very close, they're in that actively dying stage, right? And in the past, I would say things like, oh, she's got a couple days or she's got a couple hours. I have since learned that I am not God, which I think is a very important awareness for us to have. I'm not going to tell you when your person's going to die, but I am going to tell you that they will. And what I want you to be prepared for is that it can happen today or several days. Even when we've gone through the process and we've prepared ourselves and the person in the bed is maybe stopped talking and is non-responsive, and we're all very aware of what's going on. As the days go on, it actually becomes incredibly frustrating. And everybody is wondering why. Why aren't they letting go? Are they waiting for someone? Is it something I need to say or do? Are they feeling guilty? And actually all of that could be true. But the truth of the matter is, if the heart is strong, despite everything else that body is going through, we have to wait for the heart to stop. And sometimes that takes days. I was at the grocery store a while ago and I was walking behind a mother and a daughter, and the daughter was, I don't know, 7. And she said, you know, Mom, if I don't eat for 3 days, I'm going to die. And I wanted to go and touch her on the shoulder and go, actually, that's not true. Because people think, well, they haven't eaten in 2 days, they're going to die. Well, first of all, if they're dying, they're going to die anyway. But if they're not eating and drinking, that's actually kindness to the body. So they're probably not mad at you for that. But I was with a woman who did not eat or drink for 19 days. That doesn't happen very often, but that's really important for people to know. And that reminds me that we need to trust the body, that it knows what to do, not try to rush this process, and make peace with the fact that it can happen today or in several days. So what I tell my families is, okay, here's what I want you to do. I want you to imagine that this is your last day. Say everything you need to say, share all your feelings and love, make sure they're cared for beautifully, make peace with your goodbye. And if you have tomorrow, that's a bonus day. And maybe you're going to have a few tomorrows. I want you to give yourself permission to step away from the bed, go outside, take a walk, visit with your friends, have a cup of coffee, breathe, sleep, shower. You don't have to be at that bedside 24/7. People think that they have to do that, and that's exhausting. It's really important, and this is just my perspective, but I believe it with every ounce of my being. People don't take with them who was there at the last breath. They take with them who was there all along. So often people will get up to go and take a shower or go get something to eat or go to the bathroom, and they'll walk back in and their person took their last breath. Or someone's flying in from out of town and the plane just landed and they get the call that the last breath was just taken. I don't think people want an audience. And I think sometimes, because they don't want that to be the last thing you see, I think they wait for you to walk out the door. Can people be that intentional with their death? Well, let me tell you, my mom, who was incredibly dramatic, was lying in her bed, right? And she's lying there and we're all gathered around her. And this was many, many years ago. And she puts her arms over her chest and she goes, "I'm going now." And I just rolled my eyes, right? Like, oh my God, really, Mom? And she died. So that was before I worked in this field. So I just thought that was crazy. And my mom was cuckoo, but of course she did it on demand. That's just her style. So do I think people can have some intention and wait for you to walk out the door? Yes, but you didn't abandon them. They don't take with them who was there at the last breath. They take with them who was there all along. Even if you were calling long distance and did a FaceTime with them, or they heard your voice over the phone, you were there. And this thing right here, our heart, you're there with them every step of the way. And that's what matters most. Don't question your ability. And if you didn't know all these things before and you wish you could have done more, the fact that you did anything at all, whether you moved them into your home or you visited them at a facility or you checked in often or you just made a phone call, that's what they take with them. And that's a lot. Trust that you did as much as you could and don't put yourself through that. And if you are now with someone who's dying and you have these new tools, well, that's a benefit for you. And share them with other people who are experiencing this too, so they have less fear and less uncertainty. I think people deserve that. Now I know we're getting a little close to the end, so I'm going to speed things up. So hold on. I have some core values that I bring into every situation, whether I'm going to be once with this family or many times. The first one is to listen, not to fix, not to pass judgment, not to tell them what you would do or how you feel, because we don't tell people how to die and we don't tell people how to feel about dying, right? We listen to hear and to validate their words and let them know they've been heard. Presence, that's important. And what that means to me is turning your phone off or putting it away. We don't need to have the phone 24/7. I think they should be banned from family gatherings, restaurants, hospital, well, maybe in hospitals because you need to talk to people, but I think you know what I mean. We don't need to be on the phone at a bedside because what that says is your time is more important than theirs. Which brings me to showing up. Right? For me, showing up is being on time. When you tell someone you're going to be there, especially someone who is dying or someone who is preparing to say goodbye to them, when you say you're going to be there at 12:30 and you waltz through the door at 1 o'clock or later, you're telling them that their time is not as important as yours. But that also breeds mistrust. The first thing we want to do for someone who is lying in a bed and whose life is near its end is to let them know that they can trust us and that they are safe. If we show up late, they lose trust. We have to be consistent. We have to be someone they can trust. We have to be the safe place that they can go to in whatever way they need, because this is not about us. This is about them. And the most important one, at least for me, is to meet them where they are, not where we want them to be. This is not our journey. Even though we're a part of it, even though we're going to have a feeling and a reaction about it, right? All of that is true. But that person in the bed needs to feel that this moment is all about them. And they may choose things that we don't support. They may choose to stop treatment. They may choose not to eat anymore. They may choose not to take medications. They may choose not to get out of bed. They may choose to do things like medical aid in dying. For just 1 second, I want you to put yourself in their shoes. This isn't about you. We can't tell someone how to die or how to feel about their dying. What we need to do is meet them where they are and accept that their dying process and the way they see this, all we have to do is say, hey, I've got you. I'm going to take your hand. You're not doing this alone. Even if you don't support their choices, you can still be with someone who is dying and have different opinions. Your opinions aren't going to change because you supported someone who believes differently than you. It doesn't work that way. What you're saying is, I'm not walking away. I'm going to be right here because I love you, I respect you, and I don't want you to do this alone. I want to read you a song. As Susan mentioned, I'm one of the facilitators for the Humane Prison Hospice Project. It is something I absolutely love doing. And if I was independently wealthy and didn't have to count on a paycheck, I'd probably donate my time 100%. I've been to 2 prisons now, and I am just so in love with the work that they're doing. The incarcerated men and women are providing end-of-life care to the people that they are in the prisons with, and they do it so beautifully. And I went in thinking I was going to hand over all my tips and tools, and what I realized was they gave me some. But we work collaboratively to make sure that they have the tools that they need. At graduation last time, 2 of the people that I had the luxury and honor of being with and guiding and supporting on their learning, they took a song that had already been written and they changed the words around and they played guitar and they sang it to us. And I want you to hear these words. There is a hand, I will cry. I mean, I cry always anyway, so this isn't a surprise to you if you know me, but I will cry. There is a hand that is fearfully and wonderfully made, whose purpose is to serve you in your last days, whose amazing digits create amazing sounds on instruments played. There is a hand that moves with precision and grace, whose every stroke of movement captures exact image, contours, and character found in the beauty of a face. A hand that is marvelous in constructing wonders of the earth, a hand that makes it all possible, for it is the hand that facilitates birth. There's a hand that is hurting, a hand that is waiting to be held, a hand that we see do things that we dare not tell. And then there is a hand that is like magic, but this hand is real. It does not create illusions. Its every effort is to bring comfort and solution. It is the hand that gives, the hand that brings comfort to the dying. That is how this hand lives. This hand is strong but gentle. It will do the job that other hands won't do, the job that others find hard to do. This is the hand that speaks, that says, I am your strength. You are not weak. This is the hand that when everyone else is gone, it says, you are not alone. This is the hand that says, let me get that for you. I told you, I am here for you. This is the hand that waits at bedside, whether you are asleep or awake. This is the hand that gladly holds the anger, the frustration, and all that you will go through. For this is the hand that holds all of you. The hand that cleans, lifts, and remembers. The hand who touches, whose touch helps the blood flow through your dying members. This is the hand that reminds your heart that you are valuable, you are loved, I care, and you do matter. This is the hand that will greet you every day till your last days as you go on your way. This is the last hand. Every time I read that, I think of anyone who is providing end-of-life care and the gentleness that we bring to their experience, the compassion and the heart-centeredness that lets them know that they are safe and they are not doing this alone. Every hand, whether it's the professional trained hand or the hired caregiver or the family member or a neighborhood friend, any hand that holds the hand of someone who is dying, that lasting moment that you leave with them is everything. And you are often the difference between pain and peace. I want to read you as I close with a poem that I wrote. It's called Like a Butterfly. When that last breath is taken, the air in the room leaves for just a moment, leaving those in its presence holding their breath. It is at that moment when we are all reminded how truly fragile and precious life is. Life is much like a butterfly whose wings, which are delicate in nature, are powerful, miraculous, and strong. Sometimes able to make it through fierce winds, while other times no longer able to fly, feeling the wind blowing through the tiny tears in its wings, knowing that the end is near. Life is like that, fierce, strong, fragile, and precious, like a butterfly. We are all going to die. There's nothing we can do about that. How we die can be changed by the conversations we have with the people we love, telling them what matters most to us. Talking about death and dying is not going to make it happen faster. Not talking about it is not going to slow it down. Talking about it is going to ensure that your wishes are honored and that the people you love's wishes are honored. We need to have more conversations. We need to make sure that people know that we will not walk away. And until that last breath is taken, that sacred moment when that last breath is taken, we need to savor life with childlike enthusiasm, because life is fragile and precious. And we are really only gifted one life. Let the little stuff go. Don't hang on to grudges and guilt and anger and regret. Live life. Savor life. Talk to the people you love. Let them know what matters most to you. And know that you are absolutely not alone. Thank you.
Thank you so much. I feel like everybody should unmute and just like thank Gabby. Thank you so much, Gabby.
Gabby.
And please do that if you would like to.
Thank you. Thank you
Thank
very
you.
much.
Thank you. That was
Thank you
beautiful.
so much, Gabby.
So moving, Gabby.
Thank you.
You're very welcome.
Thank you.
Thank you, Gabby. It's
And if
wonderful.
you have any questions, I think there's time for questions, right?
Yes, I would ask that people mute themselves again. Thank you so much for that. And yeah, there is time for questions. There's lots of time for questions. And thank you, Ava. Yes, both of those poems were so beautiful, Gabby. And I'll see Stacy on Friday and cannot wait to tell him that this was shared in this space, because he will just get all tearful. And so much of what you said, just resonated with me. And I want to just share, because I hear this a lot from people on both sides, sort of, when people are talking about their adult children. Well, I don't want to, I don't want to burden them, or talk with them about these things, because, that's such a burden. And then you also hear things like, oh, well, the adult children, like, I'm not going to bring that up to my parents, because I don't want to bring this up. And I have to just say that my parents, I think the greatest gift I ever got, my father, of course, he died at 67 and was like just 8 months of illness, completely unprepared, wouldn't talk about anything. It was really hard to be there, really horrible experience for most all of us, including him. My mother, year before her death, I just went up there and to where she was living and said, hey, on this visit, I just want to share my own advance directives, which I've just done. I had done them prior. I had done them months before, but I wanted to put it out that I wanted to share them, really hoping that she would respond. My mother didn't like anybody to have something, she didn't. So she responded within 10 seconds of me sending that email to my two brothers and her, and did share what her wishes were. She'd written them down, but they were locked up somewhere. She didn't know where they were. She's so clear with us about what she wanted, but even clearer about what she didn't want. And then had just 10 days between the time that she had a couple of falls and incidences to the time she died. And it was enough time for her to execute exactly what it was that she wanted and not what she didn't want. And I was just so grateful that she had shared that information, that there wasn't a bunch of fights between the siblings about what we thought she wanted or what we thought she should have. And it was so different than my father's death 25 years earlier, where there was lots of conversation, lots of arguments about what we thought should be happening, which was not based on what my father wanted at all. So thank you for that wonderful reminder that these conversations are really important and can be such gifts to people. Gabby, I'm wondering if you could answer. JS has a question. If anybody would like to ask this question, you are free to use the Zoom hand raising, which is down on the bottom of the screen, under the screen of reactions. There's a hand raising one. If you use that, then I can just call on you on the order that you raise your hand, and Gabby would be happy to answer your question. JS has a question, and it's, how would you suggest dealing with anger at the end of life? My father has dementia, is in a skilled nursing facility, and we're considering bringing in hospice soon. He gets so angry and keeps blaming me, so I find it hard to be in the room with him. Boy,
Well, you're
that
not
sounds-
alone. You are not alone. I hear this a lot. And you have to kind of put it into perspective. This person has some cognitive issues, right? But they also realize that they are losing their independence and their ability to do pretty much anything. And that's frustrating. Anger is a very common way of projecting your emotional reaction to everything that you're feeling. It is not personal, but it is usually directed to the person closest to them, because that's the safe place to put it out there. It's hard for you, and I can appreciate that. But again, it's not personal. Oftentimes, this is when facilities especially may consider some sort of medications like a Haldol or something, which can help with that, the really agitation and anger and those reactions. I think it's, if I would do anything, at least what I do when I meet with somebody who is angry, is I just look at them and I'll just say, I'm so sorry you feel that way. I will do what I can to change it, because many times, especially with someone who has cognitive, like dementia or Alzheimer's, or just having confusion and delirium at the end of their life, I think when we argue with them or correct them or try to change it, that just makes the anger worse. This is one of those opportunities where you can meet them where they are, not where you want them to be, and just simply let them know that they're heard. Or you step out of the room, you take a deep breath, and then you come back in and just say, you know what, Dad, I'll be right back. I need to take care of something, and I'll be right back. And take a deep breath. Don't beat yourself up, and try it one more time. You may need to take a longer breath, and you may need to take more of them. But again, it's just not personal, even though it feels like it.
You know, Gabby, I want to just share also, one of my closest friends back in the 80s died of, many of my closest friends died of AIDS, which got me on this sort of path to end of life care. But one of them, which was the dearest person, which is such a kind heart, he had AIDS dementia along with just the AIDS diagnosis. And he took this out. He was so angry all the time. So I would go in the room, I would be like doing whatever I could for him or just to be there. And he would just be so angry. And at the time, Stephen Levine was a very close friend of mine. He was my teacher and mentor. And I asked him about this once, and he was like, well, how long are you sitting in that room? And I'm like, oh, I'll go for 5 or 6 hours a day. And he was like, and how long is he angry? I was like, oh, 5 or 6 hours a day. And he said, say something very simple like, this really hurts my heart when you're angry at me like this. And then say, I'm going to leave now, and be very specific about what you're doing, not to blame him, but just say how it makes you feel. Walk out of the room and do whatever you need to do in that time, like as Gabby said, because they may or may not remember that you've just been there. Then walk back in the room, happy to see them, just, and if the anger comes up, I did this with my friend, like for 2 or 3 days, like I was in and out of that room. I was probably out of the room in the hall more than I was in it. But after 2 or 3 days, the anger that he exhibited at me really, really, really slowed down, like almost entirely. And I don't know what can account for that, except for the fact that he wanted me in the room more than he wanted me out of the room. And he was just angry. So I don't know if that's helpful, but it sure was helpful with us. There's a couple, Kimberly has her hand up, and there is a question. There's a couple of questions we'll come back to But let's have, we'll come back to Jess's question and then Eva's. So Kimberly, do you want to, yep, I'm going to add you down here. There you go. If you want to unmute yourself. Thank you.
Yes, thank you. This is beautiful. Oh, unmute myself. Yes, thank you. This is beautiful. I studied end of life with TCM, traditional Chinese medicine doctor and acupuncturist. There is so much ancient wisdom, generational, about qi flow and how the qi moves and how it progresses through the organs as it leaves the body. And there are many simple techniques of keeping the feet warm or holding or soothing, and acupuncture can be helpful. Is there any movement to incorporating some of this, at least the hands-on portion, or can you ever bring acupuncture in because it can relieve pain and soothe the system?
Absolutely. Great question. As a hospice nurse and an end-of-life doula, I have incorporated healing touch in the work that I do. You know, I think if a family member wants to bring in acupuncture, they absolutely can. Usually in hospice, we will not bring that modality into it, but it's not something we would turn away. We wouldn't, for instance, let our volunteers do that work, and our nurses and doctors would not do that work. But if that was something you wanted to bring into the care of your person, we would completely be on board with that. In fact, most of the other medicines that are out there that are not morphine, we are completely open, at least I am open to that and would welcome that. It's not something that would be incorporated by the hospice team, however, not usually anyway. But many of us who do the doula work are doing things like Reiki or healing touch. There's a lot of that. I, as a doula, do a lot of ritual and ceremony. So I will often do a lot of energy release for the room. I do anointing of the body, both before and after it dies, to release it, to thank it, to offer gratitude. So I think you can really bring in anything that brings comfort, whether for the person in the bed or those preparing to say goodbye. It is definitely something we would all be very open to.
And can the family elect for no morphine? Because I think sometimes morphine is administered because the body can flail, and that's natural. It's that the family might freak out by that. So sometimes they're medicating someone to mask the normal symptoms that can happen during death. So can families opt to no morphine if
Of
they're
course.
not in pain, just to mask symptoms?
Absolutely. You could not
Yeah.
use it at all. I wouldn't recommend that. I mean, the flailing, I would probably give something more like lorazepam, but I agree with you. I think we have to trust that the body knows what to do, and we
Yeah.
have to be really careful. I don't want to assume that someone is in pain and just give morphine. I really want to know what else. That verbal and tactile stimuli are often very comforting, and we need to trust that first, I think. But if the family says no to that, I am okay with that. I respect their wishes. However, if there is someone in my care who is suffering, and I truly believe with my whole heart that giving them some morphine, for instance, might help their breath, or lorazepam might calm their agitation, or the haloperidol might ease some of their delirium, then I'm going to stand up on my soapbox and try very hard to explain to them the why. But if their wishes are no, then we have to respect that.
Yes, thank you.
I would also just suggest too that if this is something that a family member feels strongly about, that they really talk to their loved one. Because this happened in my own family. My two brothers did not want my father to get morphine because they thought he should die as consciously as possible. And I said to them, you've met our father, right? He's been unconscious like his whole 67 years. That's why he doesn't have relationships with most of us. Why do you think he'd want to be conscious for his death? Luckily, we were able to find, and so we continued, I continued to be up all night giving him medication. And we, thank God, like in the last, like maybe 10 hours before his death, we found out he had an advanced directive where he handwritten that he wanted to be on pain medication, that he did not want to be conscious. And I was like, maybe next time he comes back again, he'll have an opportunity to be more conscious. But my brothers were making decisions really based on what they wanted in their life and at their deathbed, which was the complete opposite of what my father actually wanted. So I think for families, it's very important to have these conversations before you're making a decision for an unconscious person who then they may be flailing because the body does do that, but they may be flailing because they're in so much pain that they can't get any relief from it. And that happened with a friend of mine for 9 weeks. And it is not, I would not wish that death on anybody. She was somebody that did end of life work her whole adult life, and had one of the most difficult deaths of anybody I'd ever seen. So it's a very fine line, but if that's important to you, I would just say really have that conversation up front with the person who's ill, or everybody, just so you know where your family lands kind of on that scale.
Yes, thank you.
Thank you so much, Kimberly. And the reason that most hospice teams do not, the hospice team, even if somebody on the hospice team, if Gabby was a trained acupuncturist, Medicare does not reimburse for that. That's not a treatment like under Medicare that they would consider okay. But if the family has an acupuncturist that wants to come in and provide that care, they're paying out of pocket for that service. I don't know any hospices that wouldn't be probably happy that that was happening, because the effect for the pain and anxiety is so good.
Yes, thank you.
Absolutely.
Thank you. Let's see. Okay. So there's a question here. I'm going to put people on mute. There's a question here that Jess asked about what's the best way to find a reputable hospice care provider near your loved one. So why don't you answer that, Gabby? And I'm also going to put up the hospice locator from Medicare,
Okay.
which
What
may
was
not
the
be the
question
best,
again?
but
What is the best? So, oh, I know. So what I always tell people is to call at least 2 hospices. And the one that treats you compassionately and with kindness, go with that one. Because if they don't have the time to understand that you're stressed and worried, then they probably don't have the time to provide the care that you need. So you can pick the hospice you want. Some places there is only one, so you don't have a whole lot of choices. But Susan's going to put up the link to help you with a hospice finder.
yeah, Medicare a couple of years ago, because this was a question that happened quite often, they just put up a place where you can look and see how hospices in the area that you live in, you can put in a zip code and how they're rated. I agree that calling a hospice and asking, I personally always try to find a local not-for-profit hospice, because there are lots of national for-profit hospices that will not provide the best care possible for the patient. So did everybody see that? You can just click on that. And then Eva asked, maybe Gabby, you could just say a little bit about the kind of the classes, and it's personal courses. So Eva, could you clarify, are you asking, does Gabby offer one-on-one classes with people? Or are you asking if there's, like courses that Gabby teaches online?
Well, I can actually answer to both of those just to make it.
Okay, and I'm going to put up your website too, and just know for people that you can click on any of these links that I put up and it will open up the web page for them. There you go.
So I'll answer it in both ways. I teach several classes. I think I have 5 of them. They're all over Zoom. And the one that I really recommend is the one that's coming up in October, which is my best 3 months. It is a 7-week course once a week, and it is a deep dive into your life, and I help you prepare your end of life plan. And at the end of the 7 weeks, you've had this really great deep dive into what is important to you. You have your end of life plan, and you also have a sort of a more beautiful outlook on life in such a way that makes you want to do more and savor it. And so it's a beautiful class that most people don't want to end. And so I love having that one. The next one is in October. I do some ritual and ceremony classes for forgiveness and grief. I have a self-care class that I share with a friend of mine, and I do my hospice master class. And I also offer an at the bedside, which is an introduction to becoming an end-of-life doula. So I offer classes via Zoom. I do in-person presentations as well. I also do private meetings if you want to sign up for a one-on-one. And I love to come to other places and present. I travel to other places. And so if you want to hire me to come to your company or your workplace, I would love to do that. But I also do them over Zoom. So I
Well, if you
present
get
from
Greece, Gabby, I'm happy to carry your bag there because Eva introduced herself from Greece earlier, so I'm
yes,
on.
yes, I will happily come to Greece for sure. Also,
I
there was
would,
another question I noticed in there, and I'll
Yeah.
just answer that just to make things easier for you, Susan. For The Last Hand, which is the song that Stacey Davis, an incarcerated man, wrote, I think Susan, are you able to put that on out there for
in
people?
the
Not right
email,
now, but
I don't know. Do you have it online at all, or do you just have the
no,
paper that
I
Stacy
just have
got?
the paper.
Stacy's poem. I am starting 2 hospice trainings this weekend, so I will try my best to be able to transcribe that.
You know what I'm
Um,
going to do? I'm going to put it on my Hospice Heart Facebook page. I'll rewrite it and put it there for you all. So if you can go to my Hospice Facebook page, and the link to my Facebook, if you've never been there, is on my website. In the next day or two, I will add it because it is so beautiful and I want to share it anyway, so you can find it there. My poem that I wrote, Like a Butterfly, is on my website. So if you go to the blog section and just put in the search engine butterfly, it'll take you there.
Okay.
And
And
I
now
think Linda has a question.
Linda has her hand, and we'll come back to Kimberly. Linda, do you want to unmute yourself? Let me bring you down here and add, whoops, sorry. And let me bring Gabby back. Where'd she go? Here you are. Here, let me ask you, I'll ask you to unmute, Linda, and you
Have-
should get a
Have
message
you
there.
had experience with dying people who are hard of hearing? Are they still very sensitive to the sounds and nuances around them, even if they're hard of hearing?
Yes, I think, you know what, I've had people ask me, what about people who wear hearing aids? Does it elevate their hearing as well? I think what it does, it's not like you'll suddenly be better at hearing. It's that your awareness of what is being said is clear. Now, I do think that the hearing is the last to go. So people with strong sense of hearing can, of course, hear everything. If they don't have a strong sense of hearing, I do believe that the awareness that they have allows them to hear what is going on, or at least feel it. So I can't be certain that they hear everything, especially those who have, are hard of hearing. But I talk to someone who is completely deaf in the same way I would talk to someone with hearing, knowing that in my heart, they hear what I'm saying. I believe that they do. That was a really good question.
Thank you. Let's see. Kimberly has her hand up and also has a question, another question here. Let me make sure. Here you go. About the hospitals. Yeah. Why don't you go ahead and unmute? Oh, you're unmuted. Yep. Go ahead, Kimberly.
Yes, I'm wondering when someone has a very prolonged period of time, like Jimmy Carter or others, does Medicare continue to pay for that? My grandma was in hospice for, I think, a year anyway. And also the internal hospital programs in prisons, is that just in California? Is it a pilot? Is it around the country? I would really, I think this is a remarkable idea, and it would be wonderful to promote this more and maybe get more funding and training. I think there would be a huge interest, even in Marin. We have the Marin Community Foundation. It's one of the top 10 in the country with wealth. And this is a novel idea. And I think there'd be huge support if you could launch a pilot and a prototype and then spread this around the country.
Yeah.
I'll have
So-
Sue answer
Why
those.
don't you talk about the hospice part of it, the long-term, like people who are ill, but on hospice for a long time. And then I can address Kimberly's other question. And I'll put something up with a link to our Humane Prison Hospice Project website and address some of the other things that you've just mentioned, Kimberly.
I honestly don't know how I don't know how long a person, there's benefit periods when you start hospice. And so of course it's covered under the Medicare benefit. President Carter was on hospice for a year and a half, I think. And
So,
that's a long time. But we also have patients who get on hospice and then get off hospice and then get back on again. And so I do believe, but please correct me if I'm wrong, that when on hospice, it is covered under the Medicare benefit.
Mhm. Thank you.
And then I'll
And-
have Susan answer the other question.
yes, thank you. So, that's so funny. Somebody just put up something about a terrific documentary about prison hospice, which is made by our colleague Edgar Barron. It was an Academy Award nominated film. And it is a fantastic tool that we use. We're using it on Saturday at Piedmont Gardens in Oakland to talk to some retired Berkeley staff about the need, the problem that we have. As people know in the outside world, aging is a very rapidly progressing experience for many of us. We're living years longer than normal. Same in prisons with sentencing that happened in the 70s and actually the 80s with Ronald Reagan, and in the 90s, the just say no, the 3 strikes, you're out. So we have people in prison 40, 50 years that we're working with. My personal feeling is if we can't rehabilitate somebody in 40 years, it's not really on them. And most of the people we've watched that we work with, I say this every time we end a training. By the end of November, we'll have trained 100 people in 5 different prisons. I would be so grateful if any one of those people showed up at my bedside to take care of me, because they have a singular focus to do this work. So Humane Prison Hospice Project started in 2017. A woman who was, she actually is in Marin, and she was working for an attorney's office and just said one day when the attorney came back from San Quentin, how do people die at San Quentin? And he said, horribly. So she met a nurse who's a nurse and social worker, Lady Bird Morgan, and the two of them had this idea to start training people in prison to do the care that the medical staff wasn't providing. And so they partnered then, they met Marvin Mutch a couple of months after he was released from prison after being unjustly accused and incarcerated for 41 years. And he had been to the California Medical Facility. He had seen the hospice. A friend of his died in that unit. And he was gung-ho on this happening. So the first couple of years for the organization was spent just trying to educate people, get some funding, and put the word out there about the work. There was no interest on the Department of Corrections side to have us do anything with them. About 3 years ago, the former boss at Mission Hospice became the executive director of Humane. The 3 founders kind of stepped away in the 2 years following that. I was brought on board 3 years ago as well. And just by stroke of luck, the doctor who was in charge of the only licensed prison hospice in California, and the first one in the country, was tasked with expanding those services to prisons across California, wherever they had a hospital bed, a skilled nursing facility, a memory care unit, or palliative care unit. So she was not able to do that all on her own. So she partnered with us. I spent about 9 months of my life writing a 475-page manual, and we've piloted the program in these 5 prisons and have had remarkable results in terms of the reflections that we've gotten from people who are incarcerated about the material which was written specifically for them, the benefit that this gives to the medical staff working in these environments, and the correctional care staff at the last prison we were in. A couple of them asked if we would come back and do a training for them. So this is remarkable. We didn't expect that kind of response we expected to be able to train the people that are incarcerated, but the nursing staff and the correctional care staff both want more training to be able to offer better care. So I'm going to put up, Laura, our website. We had an info. Thank you, Laura, for putting that up. And Edgar Barron's, if you look up Prison Terminal, I'm going to lobby that we offer this. Usually in the past, we've offered this once a year, kind of in November-ish, for a kind of combo with the Elisabeth Kübler-Ross and Humane, because Ken Ross is on our advisory board. So I'm going to see if we could offer it in the fall. because it really is quite remarkable. And to watch the men in prison terminal, Herky, one of the peer hospice workers who founded the program, but 30 years ago, died earlier this year, maybe in March or April, and he died being cared for by the men that he then trained to be able to do the hospice work. So things came really full circle. And please do email us there. We send very few, but like 3-4 a year emails, and we are doing informational meetings when we have enough people interested in joining us for an info meeting about the work we're doing. So thank you. Thank you so much. And the Humane Prison Hospice Project needed, that is the correct name, and that is the correct link that Laura's put up there. San Quentin, there is not a program yet because they do not have the space currently for us to be there, or for men to go up to the unit, though we've been doing a program in San Quentin since 2017 called the Brothers Keepers, now the Light Keepers. It's a peer support training program, but we are at the California Medical Facility. We're starting on Thursday afternoon, our second round of training. We're training 23 men there that are working on the unit, but don't have the training that they want. So, yeah. Thank you. And we've run out of time here, so I do want to end this. Gabby, just if you have anything else you'd like to say, then what I'll do is turn off our recording. I want to just thank you all so much. Before leaving, I'm going to put up the link to the Elisabeth Kübler-Ross Foundation. In terms of donations to keep this community education program alive. We are always grateful for anything that comes that way. And for those of you that were in a position where they were able to donate to the program tonight, thanks so much for that. Gabby, if you'd like to say something, and then we'll say goodbye.
I just want to say thank you for attending today and for being here and for your wonderful questions and for wanting to do this work and do it well. If you visit my website, which is thehospiceheart.net, I have a lot on there, which will include the podcast today, but also others that I've done with Elisabeth Kübler-Ross. And there's just a whole lot of resources. I've written 9 books. All my books are on there, my classes. I would love to see you in a class. That would be wonderful. But mostly I just want to say thank you. I really appreciate you showing up today. It means a lot to me.
Thank you so much, Gabby. Thank you all for joining us. And there will be an email that will go out. When Ken Ross comes back from his travels around the world, he'll post the recording up on the website, and then I'll send an email to you with all of these resources that we've spoken about today. And I'm going to turn off the recording. I will be able to stay in the room for about 10 more minutes. I think Gabby may have to go, but thank you all for being here. And we'll be getting an email from us on the 28th of September, an old dear friend. Maybe he's a longtime friend. It's old. He and I co-facilitated a group for young adults at a place called the Center for Attitude and Healing for many years. And he's now been doing mindfulness-based stress reduction, particularly around end of life, grief and loss. So Len will be doing a workshop for us on a Saturday morning, September 28th from 10 to 11:30. And so you'll all get an email about that through MailChimp. So I'm going to stop the recording. Thank you all again on behalf of the Elisabeth Kübler-Ross Foundation.